So the first patient you see is somebody with ear pain, and you're like, why are you here? Is this really an emergency even?
And the next patient you see is sent to the ED for abnormal labs, and you find through their paperwork that they are thrombocytopenic, and you wonder, how worried should I be for this abnormality?
In this episode of Critical Decisions in Emergency Medicine, we will talk about high-risk otologic infections, specifically acute otitis media and necrotizing otitis externa.
We will also talk about thrombocytopenia in its workup as well as potential complications.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices in Florida and all over the world.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the February 2026 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss the Critical Decisions publication, which contains 2 lessons that are bread and butter emergency medicine or things that are cutting edge.
In addition to the 2 lessons, there are also a lot of other features, such as the critical cases in Orthopedics and Trauma, the critical image, and much, much more.
So for our first lesson of this issue, we have within earshot, high-risk otologic infections. Thank you to doctors Nicole Bardakos, Sonika Raj, and Prag Mehta for writing this article.
So Danya, why are we talking about ear pain?
I know, right? So ear pain or otology is a common chief complaint with a very wide differential diagnosis. And there's a lot of them that are misdiagnosed, unrecognized, and inappropriately managed. The 2 most common ones are acute otitis media and otitis externa, but the scary thing is that there have complications that may be missed, such as necrotizing otitis externa, which we call malignant otitis externa or skull-base osteomyelitis, and it's underdiagnosed, has a lot of morbidity, and is potentially fatal. Another thing that we worry about is that when acute otitis media is unrecognized and untreated, it can result in mastoiditis. Thankfully, mastoiditis has been decreasing, but the problem is that if mastoiditis actually happens and is missed, then intracranial otogenic complications can be up to 10%. And that's a lot.
That's scary indeed, and I've definitely seen a few of those cases.
Listen, Wendy, you never want a neurointensivist to tell you I've seen complications of ear pain. That is scary.
That is true. So the article provides a great review of the anatomy of the ear. Any particular highlights?
So a couple of things that we need to remember are that the facial nerve exits the stylomastoid foramen of the skull of the temporal bone. And therefore, necrotizing otitis externa may present with cranial nerve palsy, specifically the facial nerve, and up to 20% of the cases. Obviously, if you see that, that should scare you. Another thing is we need to remember that the skull has the foramina, if we can remember that from anatomy, which means is that basically there are holes in the skull where infections can go through. So you can have like intracranial abscesses, meningitis, jugular vein thrombophlebitis, cerebral venous sinus thrombosis, all sorts of horrible things that allow that entry. And last but not least, the middle ear does have connections to the antrum with the pneumatized air pockets inside the mastoid process. The reason this matters is that that is not even fully developed in children that are less than 3, which is why it is very rare to have mastoiditis in kids below the age of 3.
Okay. Now, in terms of mastoiditis, the article also mentions there are several types. Didn't even know about these subtypes.
Yeah, so apparently there's acute mastoiditis with periostitis, where basically you have purulence in the mastoid cavity without bony destruction. And then you have acute coalescent mastoiditis, where there's purulence in the mastoid cavity with the bony destruction. There's subacute, where there's persistent infection, there's bony destruction, and that's usually those with otitis media with effusions or have recurrent but untreated otitis media. And then last, you have the chronic part, which has been there for months to years. I feel that this was helpful for me to understand sometimes the radiology reads, because I'm like, wait, you're describing things. Is this mastoiditis or not? And how do I explain that to my ENT or whoever's admitting my patient?
Yeah, good points. So what are some risk factors for these infections?
So for otitis externa, it's the typical things you think of like moisture, canal obstruction, epithelial injury. Earplugs is actually one of them. So we really got to ask about that. And then, of course, compromise to that skin barrier. So if somebody has eczema, psoriasis, radiation, and things like that. When you start to think of fungal otitis externa, obviously diabetes and immunocompromised are a big one. And with necrotizing otitis externa, the triad is always epidermal disruption, infection, and immunosuppression. And diabetes is there in 75 to 100% of patients with necrotizing otitis externa.
Wow, in terms of earplugs, what about all the earphones we wear?
I know. And that's why with some of them, the ones that are noise canceling, where it kind of like goes in there and kind of like smushes your ear. I don't know if there is a study about ear smushing headphones, but I would definitely suspect that that does cause some irritation, especially if you don't clean it or it's not the right size for your ear. How do you measure your ear size for the size of these things? I don't know. I never really thought about it.
I feel like there is some sort of a specialist who's an expert on that.
That is not me.
So you mentioned certainly otitis externa and necrotizing otitis externa. How do we differentiate between the two?
So there are some features that are typical for otitis externa is that it's pretty rapid in onset, so it's like within 48 hours. The patient reports symptoms of inflammation of the external auditory canal, so otalgia, itching, fullness, which may or may not have hearing loss. And then when you look at it, you do see that there's either tragal or pinna tenderness, canal edema, canal erythema. There may be autoria. And then there may be other things in the area like obvious cellulitis, lymphadenitis, and so on. Now, the tricky part is that with necrotizing otitis externa, there's no actual set criteria. It's just basically otitis externa, but worse. So you would think of it, obviously, in patients with the correct risk factors, but then they would have the symptoms for 2 to 3 weeks. It's getting worse. It's worse with mastication. It's refractory to anti-pseudomonal antibiotics. And then obviously, if they're super sick, they may have like abnormal vital signs and systemic signs of infection. Some people like to order lab tests and radiographic imaging to see if that is actually going to show them the difference, but it's not that consistent in the sense that normal workup does not rule out the condition. But if you have an elevated ESR or CRP, that should increase your suspicion that the patient has that condition, which is necrotizing otitis externa.
That makes sense. What about imaging, though? Can that be more helpful?
So there's no one preferred imaging modality for necrotizing otitis externa. Some people do use a CT, whether it's of the temporal bones, the brain with IV contrast, contrast MRI, which I don't even know how that's going to go if you want to order that for ear pain and ear ED. But it can be quite low. The sensitivity for CT can be as low as 48%. So just get a coin and flip it. And that's just going to be as good as your CT in figuring this out and so much faster and cheaper. But joking aside, it's really not that. So again, if you have clinical concern from the presentation, the risk factors, even if the imaging is negative, then you need to escalate that care, whether that's admission and MRI, get them to see a specialist, and so on. Mastoiditis, the same way. It's a clinical diagnosis, but if we're worried about, as we were talking about before with the bony involvement and the bony destruction, the CT may be helpful. However, again, it's not 100%, it's not always diagnostic.
Makes sense. So mostly a clinical diagnosis. What about treatment then?
So, what's really important for us to remember which organisms are causing these infections so we can treat them correctly. Now, both gram positives like Staph aureus, Staph epidermidis, and gram negative like Pseudomonas is the one we talk about the most, Enterobacter proteus, those have all been implicated in the development of otitis externa. Now, Pseudomonas is typically what we think of the immunocompromised people. Staph aureus is what we think of with purulent skin infections. And then with automycosis or fungal infections, we think of Aspergillus and Candida. Obviously, in that case, we just need to treat the organism we think there is. If it's otitis externa that's not complicated, then topical ear drops are enough. And if you have an earwig and there's a lot of canal edema, you're able to help the patient out and actually put that in there. I've seen a lot of patients come in with prescriptions for oral antibiotics. That is not necessary in most patients, unless you think they have also acute otitis media with that. They're older, they're really immunocompromised, and so on. You can just give them with the ear drops. Fluoroquinolones, especially with dexamethasone, are probably going to be the most helpful. And obviously, for fungal infections, you do clotrimazole. Some people come in and tell you that they bought over-the-counter antibiotics for their ear. They're usually talking about acetic acid, which is just really vinegar in a bottle. So that doesn't necessarily help. It has a lower cure rate. may help a little bit, especially early on, but doesn't completely solve the problem for most patients. With necrotizing otitis externa, obviously, since it's a more serious disease, we need to think of more serious treatments and more serious organisms like Proteus and Klebsiella. And for these patients, they're going to need admission for systemic antibiotics, and as well, more so if they've developed complications such as cranial nerve involvement, septic thrombosis, and so on. Again, we need to remember that with necrotizing otitis externa, another name for it is called base osteomyelitis, and therefore it's osteomyelitis. And that means it requires treatment for a very long time. That's at least 6 weeks, surgical involvement, so on and so forth. So that's just something to keep in mind about the complexity of their care outside of our ED. Oral antibiotics for very rare cases that are still very early, uncomplicated, can include ciprofloxacin. And then for the IV antibiotics, you would do an anti-pseudomonal penicillin. Last but not least, mastoiditis would be broad-spectrum antibiotics to cover the organisms that we would think of the same as otitis media, which would be your strep, pneumo, and so on. And that's where you would start with your ceftriaxone, ampicillin sulbactam, clindamycin, and if you're worried about MRSA, you can add vancomycin.
What about cases where we may need surgical assessment and treatment?
Well, complicated cases are going to eventually need surgical consultation for potential debridement and other interventions. However, the literature has been moving in the management of mastoiditis more towards medical management rather than surgical management. However, you still need to consult your specialist so they can follow up on these patients and see what else they need and make sure that they don't develop complications that eventually require surgical management.
Well, thank you, Danya, for taking us through this lesson. There's certainly a lot of great pearls about what may seem to be a pretty benign presentation of just ear pain with how severe an infection can progress. Obviously, patients may present with something ranging from acute otitis media, otitis externa, to something such as necrotizing otitis externa or even mastoiditis. And it remains a clinical diagnosis mostly, as labs and imaging may not be that helpful. But depending on how severe a patient presents, certainly you may consider some of those adjunctive tests. The big thing to be aware of is that because of the close proximity of the ear to a lot of other key structures, these infections can have complications that extend intracranially, even cause things like cerebrovenous sinus thrombosis and cranial nerve palsies, etc. So we do have to have, again, a high index of suspicion, especially in maybe patients who are particularly at risk for more invasive or complicated infections, such as with immunocompromised states and diabetes. A few other clinical features to pay attention to is the rapid onset of the symptoms, as well as, of course, systemic signs of infection. Now, in terms of treatment, majority of the cases of otitis externa may just be dealing with topical antibiotics with steroids to help with the edema. Remember that ear wick can be helpful as well. And depending on severity, sometimes you may even need up to 6 weeks of antibiotics for severe cases of mastoiditis. And then don't forget that in some of these cases, especially with mastoiditis, we do also have to get our ENT colleagues involved because some of these patients may need other interventions, whether with laryngotomy or even mastoidectomy if they don't improve with antibiotic therapy. So thank you to our authors.
Thank you indeed. Well, moving on to our critical ECG, it's a case of a man presenting with chest pain and palpitations. And then you look at their ECG and their heart rate is 210, and it's a whole bunch of irregular, wide complex tachycardia. And you start to have tachycardia as well. And you wonder, what is this and what am I supposed to do? This is a great review of polymorphic VTach and a reminder that it can be categorized to those with normal QTC and those with prolonged QTC. And with prolonged QTC, you would think more of the torsade de pointe, which is a specific subtype. The most common underlying cause of the normal QTC would be acute myocardial ischemia. So think of that in your patients. And then obviously the management, follow your ACLS, stable, unstable, and so on. With pharmacologic therapy, reminder that antiarrhythmics have a limited role And beta blockers may be necessary to reduce recurrent arrhythmias after stabilization. Definitely worth a review.
Moving on to our clinical pediatrics this month, it's a 12-year-old girl with chronic constipation. You wonder why they're coming to the ED, huh?
Every day.
But when you examine her, you do find that she has quite a distended abdomen that is firm but not rigid. And you end up getting some evaluation, including imaging that shows massive colonic stool burden with a lot of distension at the sigmoid, colon, and rectum that is up to 12 centimeters wide. Ooh.
What? Oh, I just looked at the picture. That is impressive. I definitely would encourage our listeners to take a look at the image in the article. Now, this is a reminder of something called Hirschsprung disease, which is congenital megacolon. In that, you have functional colonic obstruction. It usually presents in infancy. However, there may be some delayed presentations, such as this case that we're discussing. Now, depending on the age of the child, some individuals may present with bilious vomiting and failure to pass meconium in the first 24 hours of life. But with older children, it can be something like this: chronic progressive constipation, fecal impaction, malnutrition, progressive abdominal distension. The gold standard diagnosis is a rectal suction biopsy that shows an absence of the ganglion cells in the submucosa. And the treatment is surgery. Prior to that, serial rectal irrigations can be done to help decompress the bowel and prevent enterocolitis. Our literature review this month is of a fantastic article that we all should know about. It's the ACOG Clinical Practice Update about RHD immunoglobulin administration after abortion or pregnancy loss at less than 12 weeks of gestation, which was published in Obstetrics and Gynecology in 2024.
As we all know, maternal alloimmunization occurs when an Rh-negative pregnant person is exposed to an Rh-positive fetus, their red blood cells. And this particular sensitization would place the person's future pregnancy at risk for complications as well as perinatal morbidity. And so this is why we do the Rh testing and we give the immunoglobulin when patients are presenting with vaginal bleeding, which has been the standard of care. But the 2024 ACOG new clinical guidelines suggest that we can now forego routine Rh testing and immunoglobulin prophylaxis for patients who are presenting less than 12 weeks of gestation. And this is based on the fact that there are some studies in Netherlands and Canada where they show that there's no significant difference in the prevalence of this alloimmunization. This could potentially, of course, decrease cost for patients and also reduces things like wait times and healthcare utilizations, as well as potentially reduce potential barriers to abortion care. Now, the caveat is that some of the other societies' recommendations have not reflected this change yet. For example, the Society of Maternal Fetal Medicine does continue to recommend testing and prophylaxis. So for us in the ED, the practice is that for higher risk patients, such as those who are presenting with ectopic pregnancies or molar pregnancies, or bleeding in the second and third trimester, then we should consider the prophylaxis. Whereas for lower risk patients, for those who are presenting in the first trimester, we can forego that. For our critical procedure this month, it is on ultrasound-guided calcific tendinitis, barbotage, and lavage. I had to learn about what barbotage and lavage is.
If somebody asks if I want a barbotage, I would think that it's something on a menu at a restaurant. What is a barbotage, Wendy?
Well, you actually apparently insert a needle into this area of calcification.
No, hold on. I am not inserting any needle until you explain what barbotage is.
Right. It's to break up calcium deposits on the tendon, flush it, aspirating it to provide pain relief. But the procedure itself sounds very painful.
Okay, well, tell us more.
So literally, you take the ultrasound to help us, of course, perform the procedure in an 18-gauge needle, and you try to aspirate first. If you're successful, great. If you're not, then you can pulse sterile saline or lidocaine and attempt aspiration and repeatedly to try and again get as much of the calcium deposits as possible.
Well, apparently there are other alternatives for that, such as giving analgesics and follow up. And for the follow up, they may be treated with extracorporeal shockwave therapy or a surgical procedure. Now, if you find the description of what Wendy said very challenging, which I do, then there's something called the two needle method, where you use one needle to inject and the other needle for aspiration. And I think that you need to have a third hand for the ultrasound probe, or you can have a friend who can do that for you and actually help you hold the probe. But this way, at least, you are able to control the movement and do this a little bit better, perhaps. Something to remember is that following aspiration, a subacromial or subdeltoid injection with steroids and an anesthetic can also be used, since you're already in the space, to provide some pain relief. Our critical cases in orthopedics and trauma is a case of a 26-year-old man who fell around 15 feet on his left elbow and has an obvious deformity. And you get an x-ray and you see a transolecranon fracture dislocation and a radial head fracture.
This also sounds painful. So, elbow fracture dislocations are often the result of high energy mechanisms like the one we just described. And the most common pattern are posterior lateral or posterior medial injuries. We may have remembered learning about the terrible triad, where the coronoid process is also fractured in one of these posterior lateral fracture dislocations. The important thing is to remember that the proximity of this injury, your ulnar nerve, is at risk. And so you do have to check on its neurovascular function, as well as the fact that these patients could be at risk for compartment syndrome. So that should also be part of your assessment. Oftentimes, our orthopedics colleagues may ask for a CT to be performed after the dislocation is reduced because x-rays have a low sensitivity for detecting fractures.
Now, to reduce that, you need to consider intra-articular local anesthetics or regional anesthesia. There is also a case report about infraclavicular brachial plexus block. And then the reduction traditionally consists of traction, countertraction, where the elbow needs to be flexed slightly to unlock a coronoid process. Now, if it's just a simple dislocation and there's no significant bony injury, then you can just do a sling. However, for unstable joints, which is usually the significant fracture dislocations one, then you need to put them in a posterior long arm splint that is flexed at 90 degrees. And then, of course, they all need to follow with an orthopedist. Our critical image this month is a 29-year-old man who comes in with hand and leg numbness for 6 weeks. He reports that he needs to touch the wall to avoid falling when showering with his eyes closed. When you get a bit more history, he tells you he's been inhaling nitrous oxide. And when you do his physical exam, you notice that the proprioception and vibratory sense of both feet are impaired. And then you congratulate yourself on actually doing that test in the emergency department. And then you watch him walk and realize he has a wide gait.
Interesting presentation for sure. This is a case of what's called subacute combined degeneration, which is a demyelinating process of the dorsal and sometimes the lateral columns of the spinal cord. And the classic presentation include spastic paraparesis, ataxia, as well as sensory changes. And so certainly doing a thorough neurological exam is important because the patient may have normal sensation, but abnormal proprioception in this case. In terms of causes, in our patient, it is the nitrous oxide toxicity, but other causes include vitamin B12 deficiency and also methotrexate. The differential to consider, though, are other spinal cord processes like transverse myelitis, multiple sclerosis, or even compressive cord lesions. The scary thing is that a negative MRI does not rule out this condition. And so if you're concerned about this, hopefully we have help and additional recommendations from a neurospecialist. You would start empiric treatment, regardless of the MRI findings.
I think this is a great reminder of the importance of thorough exam and then also a thorough history, because here the recreational use of nitrous oxide was kind of like the tip that allowed us to figure this out. And people call it whippets. And the idea here, I didn't know any of this, is that nitrous oxide irreversibly inactivates vitamin B12. So all the vitamin B12 dependent enzyme mediated metabolism of homocysteine and methylmalonic acid, MMA, they become impaired. And that can be actually used as an indirect marker. So an elevation in homocysteine and MMA can be present in nitrous oxide abuse. Other causes, as we talked about, is the malabsorption of vitamin B12. And one thing that we forget about is bariatric surgery. So if you work with a population that has a lot of bariatric surgery, then you really need to think of that when they come in with strange complaints and you're like, I'm not sure what this is. You're not having a stroke, then what else is it? For our second lesson of this issue, Stem the Flow, Thrombocytopenia, thank you to Doctors Trishna Dava, Aaron Hope, Arun Jandoria, and Bernard Lopez for writing this article. It's not uncommon that we find thrombocytopenia in our workup. You're doing a workup for something completely different, and then you see the number being low, and you're like, do I need to care about this? And this is, I think, the challenge, because when do you need to raise a flag and say, we need to do something about it versus let it go? And then the other thing is, when do we need to treat these patients who are at risk for minor and major spontaneous bleeding?
Yeah, very true. Certainly, our platelets are a key component of our ability to clot. And the challenge is not only can we deal with some conditions of a quantitative platelet dysfunction in the case of low platelet count, or sometimes qualitative, meaning dysfunctional platelet function. And so both can contribute to the risk of bleeding and other complications. Now, the other thing is sometimes you can also have an abnormal platelet count on your testing, and pseudo thrombocytopenia can occur from platelet clumping. And so, really, when you are faced with a low platelet count, the first thing you want to assess is have a peripheral smear to confirm whether this is a true finding.
So, what are some causes of platelet disorders?
Well, you can have decreased platelet production due to some sort of bone marrow suppression. Certainly, you can also have immunologic or mechanical destruction. And as I mentioned, you can also have just simply impaired platelet activity, and that can happen from sometimes drugs, sometimes genetic abnormalities. So, definitely a variety.
And how do patients with platelet disorders present?
Well, oftentimes you are dealing with patients whom you may find some sort of petechial hemorrhage, and that can be a spontaneous skin purpura, some mucosal or GI bleeding, or even oftentimes maybe menorrhagia. And depending on, of course, the severity of these bleeding disorders related to platelet dysfunction, then you could also have anemia and splenomegaly presentations. In terms of particular disease conditions, when we're dealing with ITP, this is commonly in children between the ages of 2 and 5, and that can follow a viral syndrome. Whereas adults with ITP are generally presenting with the mucosal bleeding and purpura. In severe cases, even intracranial hemorrhage. In terms of preeclampsia, which is associated with gestational thrombocytopenia, or even in very severe cases, HELP syndrome, those, of course, can present with non hematologic symptoms that we are very familiar with preeclampsia. And then another condition that we're often thinking about with thrombocytopenia is TTP. And this is always taught to us with that pentat presentation of fever, microangiopathic hemolytic anemia, thrombocytopenia, renal dysfunction, and neurologic changes. But as we all know, not every patient presents with these classic constellation of symptoms. In fact, it's really less than 7% of patients have all five of these symptoms. And so any of these features should heighten our suspicions for this. And then finally, don't forget that hemolytic uremic syndrome can also present with thrombocytopenia. And this, of course, can be associated with bloody diarrhea. And so think about this in children and adults, especially older patients.
Great reminders. So, how should we work up suspected thrombocytopenia?
As I mentioned, if you do find thrombocytopenia on your CBC, then you really want to follow it with a peripheral smear. And then, depending on which of the potential differential diagnoses you're worried about, you would expand your workup based on that. Maybe a metabolic panel to look into TTP or HUS, LDH, or fibrin split products if you're worried about things like hemolytic anemia or DIC. And of course, coag studies if you're worried about other associated bleeding disorders.
Got it. So, we know what to do if a patient's presenting with life threatening hemorrhage. But how about if they're not? Are there any treatments that we should also consider for these specific causes of thrombocytopenia?
In terms of patients presenting with life-threatening hemorrhage, obviously we are very familiar with how to resuscitate them, but targeted treatments for these particular causes of thrombocytopenia include IVIG for patients presenting with acute ITP, as well as steroids. In terms for TTP, these are patients that we would consider performing plasma exchange or even transferring, of course, to a center for plasma exchange. If you don't have access to it, sometimes you can even provide some FFP transfusions as a bridge to the plasma exchange. And these patients will also need some immuno-targeted treatments like steroids as well as rituximab. And then, of course, if we're dealing with a pregnant patient presenting with the spectrum of preeclampsia, thrombocytopenia, and HELLP syndrome, of course, these patients need obstetric interventions such as imminent delivery.
All right. But a question that often comes up is when do we give platelet transfusions in these patients?
This is definitely a big debate for patients who are actively bleeding and such. Of course, it is part of the interventions you can provide to help resuscitate them and help with that bleeding process. But specifically, though, if you're dealing with non-bleeding patients with thrombocytopenia, you generally think about platelet transfusions if their platelet count is less than 10,000.
Got it. So, do all patients with thrombocytopenia need to be admitted?
Not necessarily. Even if they come in with such low platelet counts, if they're very well appearing, especially in children presenting with ITP, if they don't have any major bleeding, these can be followed up as outpatients. But if this is a first diagnosis, they may need to be admitted to, of course, evaluate and rule out other severe diseases. Whereas patients with TTP or HUS, they should be managed as inpatients.
Well, thank you so much, Wendy, for going through this article. And of course, thank you for the authors for writing it. It was such a good review of thrombocytopenia that can have such variable causes. There are things that are completely benign, but there are things like ITP, TTP, HUS, eclampsia, and each of them are managed differently and dispositioned differently. Obviously, patients with life-threatening bleeding are going to need platelet transfusions, but if they don't, there are other treatments that can be used depending on the disease process itself, whether it's steroids, IVIG, and so on. So thank you again for reviewing this.
Thank you, Danya. Now, moving on to our drug box this month, this is on eptinezumab for migraine prevention. Now, this particular drug is a calcitonin gene-related peptide monoclonal antibody, which is promising for migraine management in the ED. It has been FDA approved for migraine prevention, and it's also effective as an abortive treatment for acute migraine attacks. And the studies find that a single infusion can actually have effects lasting up to 48 hours. So potentially we can utilize this.
That sounds awesome. And last but not least, our Tox Box this month is about metformin toxicity. Now, ingestions of more than 20 to 30 grams can be very serious, especially if they're associated with elevated lactate level. I'm pretty sure that we all know that more than 15 is scary, but hey, let's say that. A pH lower than or equal to 7.2, elevated INR, those are all concerning. Now, the treatment is obviously, if they're there in time for charcoal, go ahead and do that. If not, then we need to treat as much as possible, treat the acidosis with sodium bicarb or trimethamine for pHs less than 6.9. You can try insulin and dextrose infusion to try to correct the acidosis itself, methylene blue for catecholamine-resistant shock, and then extracorporeal removal if you are able to do so for your patient. So thank you, Wendy, for taking the time to go through this issue with me. I've learned a lot. Our dear listeners, we hope you've enjoyed listening to us as much as we've enjoyed recording this.
We hope you find the Critical Decisions publication and the podcast always informative, often enlightening, and never boring.
Please reach out to us on our social media. Mine is at Dr. Danya Khoujah on Instagram.
Mine is at Dr. Wendy Chang.
And until next month,
bye-bye.